Hello, my name is Colin Lee, and I am the current antimicrobial stewardship pharmacist at Providence Health, St. Paul's Hospital in Vancouver, British Columbia. Given the vast amount of information and ongoing research, I was asked to provide an update regarding the current treatments for COVID-19. The COVID-19 pandemic has resulted in unprecedented level of research worldwide, and so please keep in mind that the information presented here may change or even be outdated as we learn more about the virus and the disease. Coronavirus disease 2019, also known as COVID-19, is caused by the severe acute respiratory syndrome coronavirus 2, SARS-CoV-2. It's considered to have originated via a zoonotic transmission associated with a seafood market in Wuhan, China. COVID-19 was declared as a pandemic on March 11, 2020, due to the significant surge in cases initially seen in Asia and parts of Europe and subsequently worldwide. To date, more than 37 million cases have been identified worldwide, with an associated death toll of more than 1 million people. SARS-CoV-2 is a beta coronavirus, one of the two genus of coronavirus known to infect mammals. Other notable beta coronaviruses include SARS-CoV, known for the SARS outbreak of 2003, and MERS-CoV, which causes MERS, the Middle East Respiratory Syndrome. SARS-CoV-2 is an enveloped single-stranded RNA virus. Host cell entry occurs with the binding of the S protein or the spike protein of the virus to ACE2 receptor of human cells. ACE2 is highly expressed in lung epithelial cells in the alveolar space. It is also found in other areas such as the myocardium and gastrointestinal mucosa. The incubation period of COVID-19 ranges from 1 to 14 days, with a median onset of symptoms of 5 to 6 days. Patients may be infectious up to 3 days prior to the onset of symptoms and be most infectious within 8 days of symptom onset. Transmission is primarily through respiratory droplets and contaminated surfaces. The R0, or the basic reproduction number, is reported to be up to 2.5, meaning one case of infection may result in 2.5 other cases. This is compared to an R0 of 1 for influenza and an R0 of 12 to 18 for measles, one of our most contagious viruses. Typical COVID-19 symptoms may include cough, shortness of breath, fever, fatigue, weakness, myalgia, loss of smell or taste, or nausea, vomiting, or diarrhea. Signs of greater illness severity include oxygenation desaturation on room air, lymphopenia, neutrophilia, elevated ALT, AST, LDH, CRP, or ferritin. Up to 15% of patients may require hospitalization, and up to 5% may require ICU admission. The overall crude mortality of COVID-19 is around 1 to 4%. This is compared to less than 0.1% for influenza. Hospitalized patients may have a higher mortality of up to 20 to 30%. The SARS-CoV-2 virus is typically detected using nucleic acid amplification test, or NAT. Rapid antigen test is available and may provide results within 15 minutes, but it is less sensitive than NAT. Test performance may be affected by viral load or sampling technique. Collection may be done using nasopharyngeal, oropharyngeal, or mid-turbinate swab. Sputum, bronchial tracheal aspirate, or saliva may also be appropriate for testing. As mentioned, there are a number of COVID-19 related treatments currently undergoing investigation. ASHP, or the American Society of Health System Pharmacists, has done a really good job in providing ongoing updates on COVID-19 treatments. In this presentation, I will highlight the results of a few noteworthy studies and won't be going over all the therapies that are currently being studied. I encourage everyone to visit the website if they are interested in any of the therapies that were not talked about today. One of the potential therapies of interest early in the pandemic was hydroxychloroquine. A known antimalarial and rheumatoid therapy, it was initially thought to be a possible therapeutic option given its observed in vitro activity against SARS-CoV-2 and its immunomodulatory and anti-inflammatory effects. Initial studies with hydroxychloroquine was problematic due to small sample size, variable time from symptom onset to treatment, confounded with concurrent supportive and other therapies, and variable dosing regimen and duration. The Recovery Collaborative Group based in the UK recently published their results in the New England Journal of Medicine on the use of hydroxychloroquine in hospitalized patients. In this study, patients were randomized to receive usual care or usual care plus hydroxychloroquine. Patients with prolonged QT intervals were excluded. Hydroxychloroquine was given as an 800 milligram dose every 6 hours for 2 doses and then 400 milligrams every 12 hours for 9 days or until discharge. The median duration of therapy in the study was around 6 days. Patients were enrolled from 176 UK hospitals. The average age was around 65 years old, 38% were female, 75% were white, 60% received supplemental oxygen, 17% were intubated, 56% had at least one comorbidity, such as cardiac disease, diabetes, or renal disease. The median time to therapy from symptom onset was around 9 days, and from hospitalization, 3 days. The primary outcome in the study was 28-day mortality, which was no different between the two groups. For secondary outcomes, the time to discharge was longer in the hydroxychloroquine group, 16 days versus 13 days, and that was statistically significant. Progression to mechanical ventilation, or death if not ventilated, was also higher in the hydroxychloroquine group. There were no notable differences in the subgroups. The study was concluded early after being reviewed by the steering committee due to futility. So the conclusion for this study is that hydroxychloroquine is not an effective treatment for patients hospitalized with COVID-19, and it may be associated with higher risk for mechanical ventilation or death and time to discharge. Azithromycin has also been a therapy of interest for COVID-19. It is a macrolide antibiotic with potential immunomodulatory and anti-inflammatory effects. Initial studies observed decrease in SARS-CoV-2 viral load in association with hydroxychloroquine use. It has been studied in a multicenter trial in Brazil, Coalition 1 and Coalition 2. In these studies, patients with mild to moderate and even severe disease were given azithromycin 500 mg daily in addition to hydroxychloroquine. The results of both studies showed no difference in clinical outcomes at 15 days. In fact, there were higher rates of adverse effects, prolonged QTc, and elevated AST/ALT compared to control group. Azithromycin is under investigation as a treatment arm in the recovery trial. Anti-HIV medications, such as the HIV protease inhibitor Lopinavir-ritonavir, has also been studied for COVID-19 due to observed in vitro activity against SARS-CoV-2. Similar to hydroxychloroquine, initial studies have been problematic, with small sample size, variable time from symptom onset to treatment, and confounding with concurrent supportive and other therapies. The Recovery Collaborative Group also studied Lopinavir-ritonavir as a treatment arm. Patients were randomized to usual care versus usual care plus Lopinavir-ritonavir. Patients with severe hepatic disease or interacting medications were excluded. Lopinavir-ritonavir 400 to 100 mg dose was given every 12 hours for 10 days or until discharge. The median duration of therapy was around 5 days. Patients were enrolled from 176 UK hospitals. The average age was around 66 years old, 40% were female, 75% were white, 70% received supplemental oxygen, 4% were intubated, and 57% had at least one comorbidity. The median time to therapy from symptom onset was around 8 days, and from hospitalization, 2 days. The primary outcome of 28-day mortality was no different between the two groups. For secondary outcomes, the time to discharge was around 11 days, no different between the two groups, and progression to mechanical ventilation or death if not ventilated was also not different between the two groups. There were also no notable difference between the subgroups. This study, similarly to hydroxychloroquine, was also concluded early after being reviewed by the steering committee due to futility. So the conclusion of the study was that Lopinavir-ritonavir alone was not effective for the treatment of patients hospitalized with COVID-19. Another therapy that has been studied for its anti-inflammatory effect is dexamethasone. Dexamethasone is thought to be effective against the hyperinflammatory and cytokine response associated with severe COVID-19 disease, thus mitigating organ injury. Dexamethasone was also a treatment arm in the recovery trial, and preliminary results were published in July of this year. Patients were randomized to usual care versus usual care plus dexamethasone. Dexamethasone was given as a 6 mg dose, PO or IV, daily for 10 days or until discharge. The median duration of treatment was around 7 days in the study. Patients were enrolled from 176 UK hospitals. The average age was around 66 years old, 36% were female, 60% received supplemental oxygen, 16% were intubated, and around 56% had at least one comorbidity. The median time to therapy from symptom onset was 8 days, and from hospitalization, 2 days. The primary outcome of 28-day mortality was lower in the dexamethasone group, and this was statistically significant. The difference was also seen specifically in patients where mechanical ventilation or supplemental oxygenation was required. There was no difference in patients who were not on respiratory support at randomization. As a secondary subgroup outcome, progression to mechanical ventilation was also reduced in the dexamethasone group. So these are preliminary results, but it does seem like that dexamethasone was associated with reduced 28-day mortality in patients requiring oxygenation. Dexamethasone also seems to be associated with reduced rates of progression to mechanical ventilation. So the SARS-CoV-2 virus may have a different natural history compared to other coronavirus in that viral replication peaks early, and so steroid use is less likely to prolong viral replication while still providing anti-inflammatory effects. Remdesivir, an RNA polymerase inhibitor, is another antiviral therapy that is of interest due to its in vitro activity against coronaviruses, specifically SARS-CoV, SARS-CoV-2, and MERS-CoV. It's currently under research and development. Reported adverse effects associated with remdesivir include increased hepatic enzymes, diarrhea, rash, renal impairment, and hypotension. The final report from the ACTT1 study group was published in the New England Journal of Medicine earlier this month. In this study, hospitalized patients were randomized to placebo versus remdesivir. Remdesivir was given as a 200 mg IV load and then 100 mg IV daily for days 2 to 10. Patients were enrolled internationally, over 60 sites. The average age was around 58 years old, 53% were white, 36% were female, 60% received supplemental oxygen, 82% had at least one comorbidity. 15% of patients had mild to moderate disease, while 85% had severe disease, which is defined as having a rest rate of 24 or greater, O2 sat at 94% or less on ambient air, on supplemental oxygen or mechanical ventilation. The time from symptom onset was around 9 days. The primary outcome of this study looked at time to recovery, which was defined as not needing oxygenation supplementation or ongoing medical care or not being hospitalized. So the time to recovery was actually lower in the remdesivir group, 10 versus 15 days, and in the subgroup of severe disease, it was also lower in the remdesivir group versus placebo. Mortality at day 15 did favor remdesivir, but was no longer significantly different at day 29. Other outcomes that seemed to favor remdesivir included time to improvement, days in hospital, days with supplemental oxygen if receiving oxygen at baseline, and new use of mechanical ventilation or ECMO. Adverse effects were similar between the two groups. So the conclusion from this study is that remdesivir is associated with improved time to recovery, and actually the benefits were most apparent in patients receiving low-flow oxygen. As of the recording of this presentation, we now also have the interim results from the Solidarity trial, which also had remdesivir as a treatment arm. Similarly, no mortality benefits were seen. Tocilizumab is a biologic therapy for rheumatic disorders thought to be beneficial in blocking inflammatory cytokines such as IL-6 associated with COVID-19 cytokine storm syndromes. The role of tocilizumab in COVID-19 was studied in COVACTA phase 3 trial, where tocilizumab was given to severe COVID-19 pneumonia patients. Interestingly, on July 29th of this year, Hoffmann-La Roche, the makers of tocilizumab, announced that they failed to meet primary endpoints, which included 28-day mortality, time to discharge, and ventilator-free days. Tocilizumab continues to be studied as a secondary randomization arm of the recovery trial. The efficacy of immunomodulatory therapies such as tocilizumab will likely be dependent on determining the timing of when to give these agents and identifying the patients who will require them. Convalescent plasma provides short-term passive immunity by giving patients with COVID-19 the plasma from patients who are recovered from the disease, essentially providing them with neutralizing antibodies. Retrospective studies suggest clinical improvement and survival with convalescent plasma. We still need to learn more about its use, such as patient criteria for administration, optimal timing and dosage, and optimal timing for donor collection. Convalescent plasma is currently being studied as a treatment arm in the recovery trial. Another therapy that is under investigation is REGEN-COV2, which is a mixture of two synthetic monoclonal antibodies directed against the different sites of the S protein or spike protein of the virus. At this time, this drug is still undergoing clinical investigations and is a study arm with the recovery trial, where it will undergo factorial randomization with convalescent plasma. Notably, this drug was recently pushed into the public eye when it was given to current American President Donald Trump as an experimental treatment during his coronavirus illness. And lastly, I'd like to mention the role of antimicrobial stewardship in patients with COVID-19. Bacterial and fungal superinfections have been reported in around 8% of COVID-19 cases. So far, no specific pathogens have been commonly identified. Empiric antibiotics have also not been associated with improved outcomes. Co-infections with influenza and COVID-19 is possible, and so it's important not to forget about influenza as we approach the flu season. It is still pretty difficult to differentiate between COVID-19 and bacterial infections. COVID-19 tends to be associated with peripheral distribution, greater ground glass opacity, increased vascular enlargement, and reversed halo signs on chest imaging. There may be some potential role for biomarkers such as procalcitonin. I know at our site, we have started using procalcitonin specifically in our ICU patients to help with differentiating bacterial versus viral infections. At this time, it's reasonable to start empiric antibiotics if the patient is presenting septic. Usual pathogens should be targeted based on the suspected infectious syndrome. Always remember to obtain the appropriate microbiological cultures prior to antibiotics whenever possible. One should consider stopping empiric antibiotics if the patient is found to be COVID-19 positive with no focal consolidation, negative bacterial cultures, no leukocytosis, and no alternative source of infection. If you're unable to rule out concurrent bacterial pneumonia, you should treat as per usual guidelines for pneumonia, consider oral step down whenever possible, and consider a short duration of 5 days if patient is clinically improved. The literature around treating COVID-19 continues to evolve, but based on current evidence, for hospitalized patients with mild to moderate disease, supportive management is still the preferred approach. For patients with severe disease, defined as requiring supplemental oxygen or mechanical ventilation, there is good evidence supporting the use of dexamethasone. Based on currently published evidence, remdesivir is still a reasonable option in this group. For most sites, remdesivir will only be available as part of the clinical trial. As we get more information from ongoing studies such as the Solidarity trial, we'll get a better idea of where remdesivir fits into therapy. At this time, we're probably going to be able to close the books on Lopinavir-ritonavir and Hydroxychloroquine, at least when used as monotherapy. We will have to wait for the results of ongoing studies to determine the role of other therapies such as convalescent plasma, REGEN-COV2, Tocilizumab, and Azithromycin.